Alexis for the brief intro here, and welcome to all of you, freshmen, prospective applicants, any under or upperclassmen in the College of Pharmacy. I appreciate you coming today. My name is David. I'm the current president of SSHP. I'm repping here, and here we have 6 incredible alumni. I feel our program at URI College of Pharmacy prepares us well to enter multiple roles across the life sciences, whether that be clinical pharmacy or not, and our panelists today are a testament to that. So we're going to get started here. You can feel free to get comfy, grab some popcorn, turn your cameras off. We're going to have our panelists on camera here, and we're going to be recording this meeting, posting it to the website. So again, welcome all. I'm going to go through our panelists here, and let's start with Brian. And I'm going to ask all of you to introduce yourselves briefly. Let's go with your graduation year, any residency training if you completed that, and your current role and practice site.
So good evening, everyone. My name is Brian McCarthy. I am URI College of Pharmacy alumni, class of 2010. Following graduation from such a great College of Pharmacy, I ended up at Hennepin County Medical Center in Minneapolis and pursued a administrative residency program. So that's a PGY1 paired with a PGY2, which was also concurrent with a master's degree from the University of Minnesota. Following that great opportunity, I found myself practicing at the University of Chicago Medicine for almost 10 years before full circle, I made it back to Rhode Island. I am currently the System Director of Inpatient Pharmacy at Brown University Health. And Brown University Health is a integrated multi-hospital academic health system based both in Rhode Island and southeastern Massachusetts. So my role is to oversee across our system, specifically the acute care services, including bringing our clinical pharmacy program to the next level, support of contemporary technology and automation and the optimization of that, and lastly, ensuring that our medications are available when they're needed. So looking forward to spending the evening with you all.
Thank you, Brian. All right, I'll go in order of who I'm seeing here. Let's go with Erin next.
Hi there, my name is Erin Connolly. I am a URI graduate. I graduated in 2020. I completed 2 years of residency training. The first year of residency was up in Portland, Maine through the University of New England. I completed a community-based residency program, although there were arms in primary care, managed care, as well as retail, corporate, and academia. After my PGY1 residency training, I missed Rhode Island so much. I came back down. I did a second year of ambulatory care residency through Rhode Island Hospital and Brown University Health. After completing my PGY2 in ambulatory care, I stayed on at the Brown University Health Specialty Pharmacy. I am a clinical pharmacist specialist in inflammatory disorders and gastroenterology through Brown Health Pharmacy. My primary practice site is in the pediatric gastroenterology clinic at Hasbro. It's lovely, but I do assist in coverage in some of our other inflammatory clinics as well. So I work in the dermatology and rheumatology clinic spaces too.
Thank you, Erin. Let's have Chris.
Hi, my name's Chris Hartley. I graduated from URI in 2021. I did PGY1 residency at Maine Medical Center in Portland, Maine, PGY2 pediatrics at the Medical University of South Carolina in Charleston, South Carolina, and I currently work at the Johns Hopkins Hospital in Baltimore, Maryland, where I cover pediatric general surgery, liver transplant, and gastroenterology.
Thank you, Chris. All right, if we can have Sarah. And if not, that is all good. We'll go with Russ. We'll circle back to Sarah.
Everyone, my name is Russ Scarpa. I graduated from URI in 2024. I did my PGY1 residency at Penn Presbyterian Medical Center in Philadelphia, PA. I'm currently a PGY2 emergency medicine pharmacy resident at Rutgers University with Robert Wood Johnson University Hospital in New Brunswick, New Jersey.
Yeah, welcome back, Russ. Russ was recently the president of SHP, so I've got some big shoes here to fill. All right, we'll go with Jason.
Hi, everyone. I am Jason Cambra. I am a clinical pharmacist at the Miriam Hospital, which is under the Brown University Health umbrella. Um, Kind of a unique path for me because I did not undergo residency training, but still definitely a path that can be followed.
All right, there we go. And we'll get into that. Absolutely, Jason. I think Sarah's off the call at the moment. So what we'll do is reintroduce her when she hops back in. I'm going to ask you all, you're seeing a lot in your roles, lots of diversity here. I'm going to ask, could you walk me through a day in the life or an interesting day you had recently in your current roles? And we'll start with Brian again. We'll do that same order.
So if you look at top 10 safety risks in hospitals and health systems, you almost always will see transitions of care where patients are being admitted to our hospitals. We're trying to get as accurate of a medication history as possible, prescribing the appropriate therapies, what they are on at home, but also the therapies that are required to get them back to baseline before we then discharge them. And upon discharge, oftentimes that is an area of high risk because you want to be prescribing the appropriate therapies and being cognizant of if there are any changes for both the patients and the patient's primary care team to be aware of. So within my line of work, it's rare, but it does occur, where patients may be discharged with inappropriate instructions or medication orders, which could potentially lead to harm. And so as a system level leader with, humbly speaking, system level thinking, it's my role and it's the pharmacy leadership team role at the Brown University Health to prevent that. So we look at the processes from A to Z, and we think about how the introduction of a pharmacist will prevent those errors. So I'm very proud to share that with some of our limited bandwidth, we did recently lend a pharmacist oversight of discharge medication orders when insulin was being prescribed. If you're not familiar, insulin is a very, very high risk medication. We demonstrated with pharmacist review that a significant number of errors were being caught by the pharmacists that then they were communicating to the discharging physicians to fix them before we would send the patients back out to the community. With that quote unquote pilot project, phase 1 type project, we took these meaningful results and we brought them back to our executive leadership team. I'm proud to share that in the past 12 months, we've been able to hire additional pharmacists that are dedicated to this responsibility. And we're very proud of the results, having captured over 50% of all discharges based on or prioritized based on risk at both Rhode Island Hospital and the Miriam Hospital. And that too, hopefully will pave the way for similar services across the rest of the Brown University Health hospitals.
We're happy to hear it, Brian. And this is just a testament to how versatile our PharmD program is. So you could go into pharmacy administration, any of the clinical pharmacy roles as well that we're going to get into. So I'm going to move on to Erin here. And can you tell us about a day in the life or something interesting that happened recently at work?
Sure. So just a little bit more context on my role and what specialty pharmacy is for those who are unfamiliar, maybe underclassmen or prospective students. So I'm an outpatient pharmacist specialist through the Brown Health Specialty Pharmacy. So medications that are filled at a specialty pharmacy tend to be high cost, high monitoring, high risk medications for more specialized disease states. So not necessarily medications that would be prescribed by like a primary care doctor. These are medications that you would see a specialist for. So under the umbrella that I work, I'm an inflammatory pharmacist, and then I work in gastroenterology. So I manage medications that you might be familiar with, like Humira, the ones that you see a lot of commercials for on TV. So Humira is a medication that's under that inflammatory umbrella, Remicade, Skyrizi, things like that. And I use those medications to help patients that are being treated for inflammatory bowel disease in the gastroenterology space. So as a pharmacist at a GI clinic managing IBD medications, my role on the team is to help with medication access, education, safety monitoring. So when a patient is diagnosed with IBD and needs to start a biologic medication that we're talking about for the treatment of their disease, the providers will come to me. I'm at the clinic with them, and they will ask me to help coordinate a medication start for the patient. So once we determine the appropriate therapy, I work with the insurance company to ensure that it's covered. Sometimes working in the pediatric space, a lot of what we're doing is off-label, which means there are a couple more hoops to jump through with an insurance company. So I help write appeal letters, peer-to-peers, talk to insurance companies about why certain medications are necessary. Whether or not the insurance wants to pay for them the first time around is a different story. Once the medication is approved, we then provide education to the family. So I'll talk to, working in the pediatric space, I'm talking to a lot of parents. This is typically kind of a high stress situation for them, with somebody that's, diagnosed with a new chronic medical condition for the first time. So kind of help orient them to what being on these kinds of medications might look like for their child. And then, if it's a medication that they need to administer to themselves, it's typically an injection. So we bring them into the clinic, we do injection training. I teach the kids and the families how to inject themselves, make sure they feel really comfortable with it before they go home, and manage their medications on their own. So it's a lot of care coordination from an insurance standpoint, and then from a patient education standpoint as well, making sure that families feel really comfortable, and it's very rewarding.
Thank you, Erin. I'll loop Sarah in here. So Sarah Cruz, we missed your introduction. I'm going to ask, introduce yourself, please, briefly. I'm going to ask your current role, if you completed a residency and where, and a day in the life in your current role, if you could. Thank you.
Of course. Sorry about that Wi-Fi issues, but we're back.
We made it back. All right.
Better than ever. Hi, everyone. My name is Sarah Cruz. I graduated from URI's PharmD program in 2021. Chris and I were in the same class. I completed 2 years of clinical residency at VA Connecticut, and I did my PGY2 in geriatrics. I now work at the Central Western Massachusetts VA as a home-based primary care clinical pharmacist specialist. For my job, I work as part of an interdisciplinary team with nurse practitioners, RNs, social work, OT, PT, and a dietitian. We have about 130 patients on our panel, and these patients are primarily frail, homebound, older adults, and I'm the medication expert on the team. My day-to-day is pretty variable, but I take my government vehicle and I'm visiting patients in their homes. I do medication management visits. It just happens to be in their home because it's easier for the patients. I also receive many phone calls and messages with a variety of questions from everyone on the team while they're in and out of visits. So I'm helping answer questions, helping solve problems. Any questions from this patient purchased a $120 supplement, and we found out that they started taking it, and the nurse wants to know if it's safe with their other medications. I do a lot of deep prescribing. I also complete chart reviews for all of my patients when they first start on the program, and on a quarterly basis, and I'm basically assessing and reassessing that their medications are safe and appropriate, and again, looking for areas to deprescribe. And I also review the details when veterans have falls to see if there's any chance that it's medication related. I also help with transitions of care when patients are in and out of the hospital, reviewing the hospital discharge information and performing medication reconciliations. So it's a lot of different things, but I really like the variability from day to day, and I like kind of knowing my role on the team and working in that team setting.
Thank you, Sarah, and welcome back. I'm going to pass it to your classmate, Chris.
So every day is kind of a surprise, but it has similar themes every day. So covering like general surgery, you get any trauma that comes in, you go to. So whether it's a burn or a fall or like a motor vehicle accident, you get sent a page on like the old school pagers, and you go down to the emergency department. And then depending on the severity, The surgeons will decide if we're going to the OR or not. And if you're getting level 1 to the OR, that means that you need to be under like now to start the procedure. So we're making sure that we're giving antibiotics, vaccines, and any other medications that they might need prior to them being intubated for that procedure. And then afterwards, it's a lot of figuring out what their post-op pain regimen is going to be. And then sometimes, depending on what has to be surgically fixed for the patient, I have a collaborative practice agreement where I'm able to write parenteral nutrition. So I write TPNs for patients. And then we also have our liver transplant program at Hopkins. And so I am the pharmacist on that team. So anything that goes from like listing a patient for a transplant, so they get listed through a panel. And then it goes into like the UNO system, and then you determine if that organ is available for the patient, and then if it's the correct size, blood typing, and then if it's a good organ for that patient. And then from there, you will have the patient usually go to the OR. And then after the OR, I have a collaborative practice agreement to dose all their immunosuppressants. So anything from thymoglobulin down to their tacrolimus, and make dose adjustments based on their levels. And then I also usually will do parenteral nutrition with them as well. And then getting them from the ICU postoperatively onto the general pediatrics floor and then discharged to home.
Yep. Thank you, Chris. No, this is amazing. I'll pass it to Russ. And Russ, to preface your response, I'll ask, what is a pharmacy residency and what is life like as a resident plus a day in the life for you?
It's a loaded question, David. So pharmacy residency, in short, is 1 to 2 years of structured training where you're working in a clinical environment, typically sort of as the primary contact for teams as the clinical pharmacist, but with a preceptor backing you up. So it's sort of like your API years, but extended with a lot more responsibility. And then for your second year, you can choose a specialty, which in my case was emergency medicine. SSHP has a lot of good content for a deeper dive into that. For my job in the emergency room, the easiest depiction, just to picture an episode of The Pit, and then just like drop me somewhere on the side of the room holding a bag of norepinephrine. That's more or less what my days look like. Sort of I go in, I just walk right into the ER, and I make sure my supplies are all stocked up in the resuscitation bays, my pumps, my poles, my syringes, all that stuff. And then we are verifying orders. So whenever a patient in the ER needs a medication, the doctor orders it, and then it actually goes to my computer first to just double check, make sure it makes sense, the drug, the dose, the duration, and also like, is this the right thing for this patient based on what we know about them? And then we have this tier triage system where if someone's critically ill, they go straight back into our combo resuscitation and trauma bay. So if we get a trauma, could be adult, pediatric, or any sort of critically ill patient, could be a sepsis, could be an arrhythmia, could be a cardiac arrest. They'll come through to our bay, and then I'll go back there with the team. There'll be an attending physician, a resident physician, some nurses, some clinical care technicians. And I have my Pyxis, which is like a vending machine for drugs that I can open up, and a computer if I need to look anything up. And we just sort of work together as a team to stabilize the patient. And they'll go up to a specialty service like what Chris works on, or they'll come back into the main ED for us to continue to care for, and so we can figure out where they will go for the next part of their healthcare journey. That's
Thank
the
you,
long
Russ.
term of it.
Yeah. No, we appreciate it. And a quick shout to our program. We do have the #1 pharmacy residency match rate in the whole Northeast. So this is the place to be, by the way, any prospective applicants. And if you want to learn more, come to our meetings, SSHP, any freshmen or prospective applicants if you do make it here to URI. I'll pass it to Jason. You're in a real niche of pharmacy here with IDS. Can you tell us a little bit about what IDS is, what that looks like for you day to day? Thank you.
Yeah, so IDS, also known as Investigational Drug Services, is a service that's offered at Rhode Island Hospital and at the Merriam, where I work. Essentially, we are in charge of making sure that all the clinical trials that are operating within the system are functioning properly, making sure that they're following protocol for everything. And that comes along with working with the nurses and the doctors that are overseeing the trial sites that we have, making sure that the medications are properly stored and under all the correct conditions, so just so that it follows the protocols all correctly. And then making sure that it gets up timely to the patients, whether that be in an inpatient setting or at one of our outpatient clinics. So I cover that on a day-to-day basis, depending on whether it needs coverage. We do have a couple of people, thankfully, that help with that. Day-to-day otherwise depends on what else needs coverage. So I could go from going to internal medicine rounds, which would be rounding with one of our teaching teams at the Merriam, going through making sure all their patients' medications are correct, being present at rounds and working with the team just to make sure that if they have any questions related to any medications, making sure that all of those are answered. And then also I am trained to cover our transitions of care service, which provides education to patients that are going to be discharged home. That would be related to new medication regimens, new medication starts, and then also teaching about certain disease states such as heart failure, COPD, et cetera.
Thank you all. I'm now going to flip the order for the next question. And by the way, everyone, we now have a really good overview of 6 different roles in clinical pharmacy. Feel free to ask any follow-up questions to any of them individually or to all of our panelists in the chat. I'll get to those at the end, and I'll be asking them. So I'm not going to ask, and I'll start with you, Jason. What is the most challenging part or one challenging aspect of your practice in IDS, transition of care, et cetera, and name one rewarding part as well?
Honestly, I think transition of care can be both the most challenging and the most rewarding, both at the same time. Only that because of the fact that everyone comes from a different background. And so when new diagnoses are given to a patient, whether that be for heart failure or COPD, if it's new for them, it's probably very scary, which can be challenging to help walk a patient down off of the cliff of saying, oh my gosh, I have so many issues now. But also that's the rewarding portion of it as well, just because you're there to be a guide to them and help answer any questions that they do have. A lot of times you end up having these really great conversation with these patients and getting to know them on a more personal level, more than just looking at a chart on a screen, which is where a lot of what we do normally comes from. And also the fact that in getting to spend time with them, you learn about who they are, how you can help them on a more personal level, and make sure that everything happens to get them healthier in the future.
Yep, thank you. I'll pass it to Russ. And Russ, I'll ask you, what have been the most challenging aspects specifically of your transition into residency? What are some of those more rewarding aspects like autonomy in your new role?
Another very hard question, David. You're killing me. So I think when you leave URI, you have this phenomenal foundation of knowledge. And then once you start residency, you realize that phenomenal foundation is the thinnest layer of ice on top of like a giant ocean of like things to know. So when you first get into residency, you realize how much you don't know. And then you spend the next 2 years of your life trying to build that up into something that feels like you can be confident in front of. I think Chris is laughing. I think he agrees. There's a lot to learn, and it's your responsibility to know what you don't know and to learn how to find that information. And even like once you're done residency and entering practice, I'm sure there'll be things every single day that I still have to step out and look up. And part of the battle is knowing how, where, and when to find that info.
There you go. No, it's good. And I'm going to ask your advice for students in a future question, but we'll get to that. I'm going to move this on to Chris. Challenging and rewarding aspects of your current work in pediatrics.
Yeah. So the most challenging part, I would say, is not having literature or trying to give something like the most educated guess that you can give. So the majority of the time, there's not great literature. Your medications aren't FDA approved for that indication or for that pediatric patient, or it's a patient that is, super small. So For example, like some of the babies in the NICU that they'll have as like a surgical patient might be like the smallest patient that I've seen has been 300 grams and like 24 weeks old, so super premature. And so there's not a lot of literature behind what medications you can give, what doses you give to these patients. A lot of things are weight-based. Kidneys don't work super well. Your enzymes in your livers is very different than an adult patient. And so trying to figure out what's the best dose to give, or it's a medication style that you don't have great literature in. So for example, right now we're working on basically like if you've ever watched Grey's Anatomy, when they have like the hearts in a box or like a liver in the box, those are like real devices. And so they're like normothermic. So it keeps instead of putting like the organ on ice, you put it into the box and it perfuses the organ with blood. And so figuring out what medications you can give inside of that box, where you'll still have the drug being metabolized by the liver. So the drug is broken down into different forms within the new liver within the box, but there's no way to excrete the medication from the box. And so figuring out what those metabolites will do long term while you're setting up for your transplant surgery. And so it's a lot of figuring out that kind of stuff. I think the most rewarding part of it is being able to, see these patients get healthy and see them live a like long and fulfilling life. So, getting to see pictures when they're graduating high school or getting to see pictures when they're like going off to their first day of kindergarten.
Yeah. No, pediatrics is a challenging and rewarding field at the same time. So be cognizant of that, all our underclassmen. I'll pass it to Sarah.
A challenging part about my job is when my patients are new to me and new to the program. They are veterans, they are older adults, they have these long problem lists. They're very complex, very sick. A lot of them are having a lot of falls in and out of the hospital, and that's kind of why they were referred to our program. So a lot of times we have to start from scratch. A lot of times they haven't been seen by their PCPs or healthcare providers for years because it's just really hard for them to get out of the home. But yeah, my patients are sick and sometimes they're nearing the end of their lives too, which can be very sad. But on the other end of this, my team we are a great team. We offer all these different ways of thinking, and we can help these patients in very different ways and kind of individualize our care to what they need and provide that support. So I really like following these patients long term and kind of seeing where they start. And then like there's a point where they just kind of stabilize, and the patients and their caregivers are very grateful for our team because we can provide that extra set of eyes, the extra oversight. I can go in to help with disease state management and can prescribe and provide extra education as well. So just seeing the patients and the family members get more comfortable with us and start trusting us. And I get, random phone calls from patients all the time because they feel like they know who to go to, they know who to ask their questions, and they can depend on us. So I just think we take a lot of stress off of these patients and can help them be more comfortable and more controlled with their different diseases, which is nice to see.
Thank you, Sarah. I'll pass it to Erin.
As with, I think a lot of healthcare today, a major challenge that I face at work every day is just insurance coverage and insurance restrictions. So as I kind of mentioned before, when I outlined my job responsibilities, I am one of like the key players on my team in medication access and coordination. So I help facilitate a lot of prior authorizations for these high cost specialty medications. And oftentimes the medications that I'm assisting and prescribing require multiple levels of prior authorization, appeals, multiple levels of appeals, external review, that kind of thing. And it can it's a lot of paperwork, and it can be pretty burdensome, and it can limit patient care and cause care delays. So when patients are pretty sick and you're trying to get them started on something new, managing all of that can be very challenging, and it's time sensitive. So luckily, I work with a really great team of pharmacists and pharmacy technicians that help coordinate those authorization issues as well. Brown Health has a pretty robust system in place where we have a medication access team where other pharmacists and technicians are able to kind of coordinate some of that authorization stuff behind the scenes. So I'm able to focus more on providing care in the clinic and some of the higher level issues related to authorizations and access issues. So outside of that kind of care coordination piece, I think that the most rewarding part of my job is working directly with patients who are in kind of a ambiguous and kind of scary moment in their lives, whether or not they were just diagnosed with inflammatory bowel disease and they are starting a medication for the first time, or if they were on a medication and it's not working for them well anymore. Starting a biologic or changing a biologic can be really sensitive and scary for people, especially because some of these medications that I'm working with come with a pretty long list of side effects, concerns, they're immunosuppressive, that kind of thing. So I'm able to walk families and patients through something that can otherwise be pretty scary for them, humanize it a little bit, make sure that they feel well taken care of, and help them get through a hard time and feel comfortable and confident in their care. Working directly with providers in clinic is really special too, feeling like an integrated part of the team, and helping kind of see patients through challenging times is really rewarding. So one of my favorite things is working with kids that are going off to college and are on these medications, trying to make sure that they feel confident. Previously their parents were helping them coordinate their medications when they're at home, and now they're heading off to college for the first time, and they're getting ready to move into their dorm, but they're also needing to kind of take care of their injections and that kind of thing on their own for the first time too. So helping walk some of those kids through that kind of complicated process as well, and making sure that they feel confident managing their healthcare on their own is something that I find really rewarding in my day.
Thank you so much, Erin. I'll pass it to Brian.
I had a boss in Chicago once upon a time communicate to executives that were curious about what would be the next big thing for our pharmacy enterprise to focus on. And my boss had communicated that he used an analogy that a pharmacy enterprise, specifically within an academic health system, as far as the opportunity is concerned, you're looking at a big cheesecake. And whether you like cheesecake or not, sometimes they look pretty appealing and you want to eat the whole thing, but you can't. You can only have one little slice at a time. So what's challenging in my role is through networking and benchmarking and our familiarity with how academic health system pharmacy practice works, we know the playbook. We know what needs to happen. We know what we want to do. We know the cost reduction initiatives. We know the revenue generation initiatives. We know the patient experience initiatives. We know the quality improvement initiatives, and we know the medication safety initiatives. But there are only so many hours in the day. And then secondly, a lot of these initiatives are interdependent with other service lines within the hospital. So for example, if we know that we want to implement a new solution within our electronic medical record that will decrease the likelihood that a patient in our ICU gets hypoglycemia, that is one of 50 or 100 requests to that IS team or the information service team that's responsible for building out our electronic medical record, and it falls into a prioritization queue. So you can get a little restless with knowing that you have an opportunity, but you're waiting in line. What's fulfilling, there's many things that are fulfilling in my role, but one that comes to mind is within my lifetime at least, we have decoded the human genome. So in other words, within DNA, we know the sequence. And what that has allowed the pharmaceutical industry to do, to accomplish, is nothing short of miraculous as far as some of the cellular and gene therapies that are continuing to hit the market. So for example, there are patients that are born with what's called hemophilia B. In other words, these patients don't have the same blood clotting factors that most of the population does. And so if and when they get cut or start bleeding, it's a scary situation because they cannot stop bleeding. This is a condition that requires lifelong, almost weekly infusions, where a patient, imagine the disruption on that patient's life, to get weekly infusions of the factor or the clotting mechanisms that they were not born with. Well, in any event, there are new cellular and gene therapies that are curative of hemophilia B. They cost millions of dollars and they're very complex from a procurement standpoint. How do we get this medication from where it's manufactured? How do we store it? How do we dispense it? How do we work with that patient's medical insurance to make sure that we're paid for it? And lastly, how do we administer and monitor the patient to reach the intended outcomes? And that is a true story. We treated the first patient in New England outside of Boston earlier this calendar year. And certainly it's easy to argue how fulfilling that is to change your patients' lives with the scope and the experience that we bring to the multidisciplinary team.
Yeah, exciting times in pharmacy, absolutely. And I'm going to ask you an experiential question now. If you could all go back in time to when you start pharmacy school, like many of the members in our chat now, I'm going to ask, what advice would you give yourselves in a 30-second or 1-minute conversation, like a few tidbits that you want yourself to know? And I'm going to start with you, Russ, because you mentioned this ocean of knowledge that you're confronted with as a resident in clinical pharmacy, and then we'll jump back to Jason. Thank you.
So what's the exact question?
Yeah, advice to yourself when you start pharmacy school.
Work hard and take opportunities, which I think I did a good job of following that advice at the time. But the biggest thing is just to remember what you do in the classroom is just sort of the minimum. Whenever you see opportunities to get involved, like this is HP or with Rhode or with Habitat for Humanity, which we have a chapter at URI, anything that really sparks joy for you, where you can contribute to your community and grow as a person, those things that you're doing just to do them become leadership opportunities. And although it's not really the point, they also become CV builders, and it really makes you a better person and a better clinician. So look outside the classroom, take a job on campus, keep moving, keep working.
Yeah, no, good advice. I'll pass it to Jason.
I think really the biggest piece of advice I would tell myself is don't be afraid to explore a lot of different avenues of pharmacy as well. Like Russ said, getting involved is really, really important, but also knowing how many different disciplines in pharmacy there are is also pretty daunting, and you don't learn a lot of them right away. It probably takes a couple years before you fully flesh out everything. And even now, I'm still learning about different areas of pharmacy that I would have had no clue about to begin with. So I think exploring your options is really good and not being afraid to take any chances on any cool roles that you see.
Yep. And you don't know what you don't know. So on the student side, none of us bite in student pharmacy organizations. So feel free to come to any of our meetings, ask any of us questions if you see us floating in the hallways in Avedisian. We're more than happy to chat. And I'll pass it to Aaron.
I would say advice for myself as a freshman, get involved early. Don't be afraid to go to pharmacy specific organization meetings as a freshman or a sophomore, even if you might not feel at home in Avedisian just yet. Really important to build a community of people around you and to get to know other older students early too, if you're able to. So one of the most valuable things for me when I was a freshman and sophomore is I took a chance and I joined a pharmacy organization early on. It was the Christian Pharmacists Fellowship, and I met a lot of really nice older pharmacy students who were able to guide me and coach me through some of my non-pharmacy things that were going on for myself before I actually started the professional curriculum. Made me feel a lot more comfortable when I got into my actual pharmacy classes, and I felt like I kind of had a network of people behind me. I also had a campus job where I worked with another student who was a few years older than me, who was in pharmacy school coincidentally, and she's actually my coordinator now. So we work together closely to this day. So pharmacy is a very small world. It's small when you're in school. It feels even smaller sometimes once you've graduated, and the more people you're able to get to know in an informal way before you kind of enter into the workforce and residency, that kind of thing, the better. Helps you feel really supported, as you're navigating school, which can be really challenging.
Yep. Thank you. I'll pass it to Chris.
I would say you don't need to be a straight A student. I definitely was not. And grades are important. But a lot of the time during school, there's one right answer. So it's multiple choice. And then when you get to the real world, there's a lot of different answers that you can go with. And so making sure to also, diversify your portfolio by taking advantage of whatever opportunities you have. So saying yes to things. And that usually will get you very far in the long run.
Yeah. We'll go to Sarah.
I think for me, the pharmacy program is very structured. There's a lot of boxes to check, a lot of non-negotiables, which is good for like the typical type A pharmacy student. And it's definitely a lot squeezed into a short amount of time. But my advice would be that when you have the opportunity to kind of individualize your experience, whether it be professional organizations or electives, or when you get to your APPE rotations last year, just to be very intentional about your decisions. It's okay to not know exactly what you want to do in the future, but it's important to pursue different opportunities that you think might be a good fit, and kind of periodically check in with yourself and make sure that your plans and like the time and effort that you're putting into things are in alignment with your interests and is kind of setting you up for the future. I know I started off in like 5 or 6 pharmacy organizations, and I was like, I'm gonna be the best pharmacy student. I'm gonna join them all. But you quickly find out that there's only a limited amount of time in the day, and it's better to like quality over quantity. It's better to be in one organization that you really care about. And I was in ASCP, which is geared towards geriatrics. So I got to be on a leadership board. I got to be involved in a lot of events. And then you have a lot to speak towards because you were like very involved in something that you're passionate about. So just being very intentional with your decisions through those 6 years and afterwards.
Thank you, Sarah, and we'll pass it to Brian.
The advice I'd give myself earlier in my career is advice that I received in the middle of my career, and it's an oversimplification, but I think it rings true, and that is to work hard and to be nice to people.
No, beautiful. All right, so now that we're here, I do have a bonus question at the very end, but I'm going to give everyone time to think of questions that they want to ask any of our panelists or all of you all together. I know we have some people planning for APPEs, those are current P3s, some people not even in pharmacy school yet, and some freshmen as well. One of the questions is, as myself and this one of my classmates and the rest of the P3 class are planning for APPE rotations, what advice would you give us in terms of planning the APPEs out? And we'll start with Brian. We'll do a reverse order.
So for the preceptors, and if you are interested in a residency, for example, it's worth noting that residency program leadership sees a lot of candidates. And with a lot of candidates, you get to see a lot of letters of recommendation, but you also see a lot of pathways that pharmacy students take to their current qualifications or candidacy. And I'll also say that whether this comes as a surprise or not, but residency program leadership, if that is what you're interested in doing, are familiar with easier, relatively speaking, APPEs and more challenging routes. And so my advice for the P3s that are designing, planning your APPE rotations is to challenge yourself, be intentional, partner with your APPE coordinator. Don't take the easy routes. This is the opportunity for you to challenge yourself in real world practice. And no matter what the next step of your career path is, you're doing yourself a disservice by missing out on some really cool, neat learning opportunities that often do come with some of the more challenging APPE experiences.
Thank you. I'll pass it to Erin.
Echoing what Brian said, if you're, at the stage now where you're looking through, the available APPE rotations and starting to rank them, really important to step outside of your comfort zone and challenge yourself. Don't just pick the elective rotations that you think you are gonna like. Think about things that you feel uncomfortable with in pharmacy school so far, things that you maybe haven't seen very much, and try to find elective rotations on those related to those kinds of things too. So, remind yourself that this is an opportunity to learn something you haven't learned yet. So, try to avoid confirmation bias. Don't gravitate to the things that you feel like you're going to be really good at. This is an opportunity for you to learn in a controlled environment. And, it's okay if you go into, say you do a APPE rotation and specialty pharmacy and it's not something you're comfortable with based on, what classes you've taken. Nobody's going to expect you to come in and know as much about specialty pharmacy as you knew about diabetes, or even nuclear pharmacy or something like that. Nobody's going to expect you to know everything about those things on day one, because it's not something you're familiar with based on the curriculum. So understand that if you pick a more challenging or niche rotation that you don't know much about, you're going to learn a lot and you're going to learn in that controlled environment. So just give yourself, some grace to pick something hard, and just really soak it all in.
Thank you, Erin. I'll pass it to Chris in a minute. We do have another question in chat that we'll get to after this round.
Yeah, so I am the residency program coordinator at Hopkins. And so I would say one of the things that we're, looking for is definitely, more challenging rotations, but then also making sure that you're giving it your all and asking for more projects if you have the time and bandwidth to be able to do that. So making sure you're going above and beyond on that rotation. I think that it's also important to make sure that if you haven't done research yet, ideally trying to get a poster for some type of conference prior to interviews, just so that you have that on your CV, and then making sure that you're setting yourself up nicely. It's good to know what you're interested in, but I think it's also equally as important to figure out if you're not interested in something. And so say there's an area and you take a rotation in, I'm going to say oncology, because that's an area that I don't particularly enjoy, but I love that people do enjoy it. And so if I had an APPE rotation in oncology and I realized I really didn't like that area of pharmacy, then that's great to know for going forward, that that's not an area where I would want to pursue for my career.
Yep, good advice. Yep. I'll pass it to Sarah now.
Similarly to what Erin was saying, when I was looking at APPE rotations, I felt like I wasn't very strong in diabetes, but I knew I wanted to do something in more ambulatory care side, and I knew it would be important. So I selected a rotation for that. And also I just want to throw in there that when you're working with trying to figure out what rotations, high risk, high reward can be a thing. I was interested in VA Connecticut. So I talked to Dr. Ferret. They had a couple rotation opportunities there. And one of them, my preceptor was the RPD of the program. So high risk, high reward. I worked hard. it went well and I ended up matching there. So if you have that opportunity, it's like can be a little nerve-wracking, but it can pay off as long as you're, trying your best and putting your best foot forward.
Thank you. I'll do Russ, then Jason, especially because you two just went through this. So interesting perspectives here.
Yeah, I'll endorse what everyone else said and really emphasize if there are areas that you might be interested in, I'd recommend doing them early in the year, which you don't always have the luxury of choosing, but you could talk to Dr. Ferret. Our experiential office is fantastic, especially getting clinical rotations in the first half of the year, so then you have something to speak to during residency interviews in the second half of the year. So Gen Med, Crit Care, EM electives, any of those things will be really great to actually give you some interventions and experiences you can discuss.
Thank you. And Jason.
I do agree with everything that all the other panelists said, but I think another part that I can speak to is trying to explore other options other than just doing it with faculty members at URI. There's going to be a lot of faculty members and professors that you'll know that have rotations listed, but I think exploring your other options and then trying to do it with other pharmacists is also really beneficial because although they're not going to be perfect at maybe the teaching aspect, you'll get to see what they do in practice a lot more, which is also really beneficial to see as well.
Yep. Thank you. Thank you all for that question. We'll get to this last question here. Chris, you gave a great response in chat. So I'm just going to ask this to Aaron, Brian, and Sarah, because Russ and Jason, you're pretty fresh graduates, unless you have your 2 cents. It is, how do you go about maintaining relationships with your preceptors after rotations and even now into your career? I'll start with Brian.
So, it kind of ties back to the previous question, but it is worthwhile that if you're going to have an APPE experience or maybe even an IPPE experience, on day one, it's worthwhile to make it clear what your intentions are, what you would like to do with your career, what you hope to accomplish during the next 4 or 6 weeks or whatever it may be. And, to be bold and say, look, I want to be one of the best students you've ever had. I'd like to earn your trust. I'd like to earn your letter of recommendation someday, and try to be as genuine as possible and live up to that. Following a 4 to 6 week learning experience that you have together, you'll recognize that despite these folks being preceptors, they're people as well. They commit to relationships. They hope for bidirectional trust. They hope for bidirectional care and appreciation, and they hope for bidirectional, challenge. And if you can accomplish those 3, you've established yourself a nice relationship with that preceptor. And so it should feel organic thereafter, checking in, see how things are, but especially if there's ties to what you're hoping to accomplish with a letter of recommendation or an endorsement or connecting to a future opportunity someday. So I don't have a blueprint or a playbook per se to say reach out via email every 6 to 8 weeks or anything like that, but whatever you do should feel genuine and altruistic.
Thank you. We'll pass it to Sarah.
I think when you're working with preceptors, it's important to remember that you are kind of a guest. They are, still expected to complete their day-to-day job. So it's good to show interest. It's also good to read the room. We have a lot of questions, a lot we want to learn, but being mindful of their time and when's maybe a better time when there's a lull rather than when they're in the middle of putting out 5 different fires. I feel like it does happen organically, just making sure to be respectful of your preceptor and their time. And then afterwards, I feel like I have run into all of my preceptors in other areas just down the line in my career, especially staying with the VA. And you can definitely utilize your preceptors afterwards and just check in. I feel like they like to hear updates, if of where you are in your career. And all of mine have been good resources later on if I have like professional questions. And I do agree that it happens organically as long as there's respect in both directions and it's a positive experience.
Thank you. I'll move it to Aaron in a second, but in chat, some great nuggets of advice. Chris mentioned it's definitely beneficial to reach out after the rotation ends. And shout out LinkedIn, as Russ said, great tool for maintaining professional connections after rotations end and furthermore. So I'll pass it to Aaron now.
I think that Brian and Sarah hit on some really great points. It really is important it ends up being organic. One thing that I'll add to is thank you goes a really long way. People are precepting because they want to and they want to help you learn and they want to stay connected with younger pharmacists and pharmacy students. Sarah mentioned, I liked what she said about, you are, especially if it's not a faculty rotation, you are a guest in their clinic space. So they are taking time to provide, high quality education to you in addition to their responsibilities during the day. And they're doing that because they want to foster that relationship and teach you. And one thing that, I've really appreciated having precepted a lot of pharmacy students and pharmacy residents is if you really did enjoy your rotation experience and you learned from that person and you saw the work that they were putting into, helping you throughout the day, as all preceptors really do. Thank you at the end of it goes a really long way. And thank you cards and thank you notes aren't as common as you think they might be, having, gone through rotation experiences and then precepted people. So just don't be afraid to express your gratitude too. That kind of helps you maintain that connection.
100%. Bring the cupcakes to the pharmacy. Everyone will smile. So
I don't know if you need to go that far, but a thank you goes a long way.
Don't break the bank. So thank you all for the lovely responses, all the advice you've given our students. Anyone else, if you want to unmute quickly, we can get in one more brief question, have like a one-liner for someone. But again, this is great. I'm going to shout out to all of our URI 101 attendees. Scroll up in the chat, fill out that Google form so they can record your attendance for this activity. But again, thank you all. I really appreciate your time and great to see you all again. Anything else, Dr. Estes, or all set?
All good, everyone. Thank you.
Have a good night, everyone. Good luck on Calc. All right.